So Parkinson's disease essentially is a lack of dopamine in the brain. There's dopaminergic cells. Here is a picture of the substantia nigra. The substantia nigra is where dopamine cells reside in the brain. So you can see here at the top that the person, the portion at the top has less pigment than it does at the bottom down there below. The pigmented cells are the area where the dopamine is, and that's how you can tell there's a difference between Parkinson's disease and in a normal person. The abnormal protein in Parkinson's disease is called the Lewy body. It is an accumulation of alpha-synuclein, and that's what you see up in the upper right-hand corner there. And that shows you the pigmented nigral neuron. So this is a complicated slide, but basically what it is, this is the diagnostic criteria for Parkinson's disease. So the major cardinal symptom of Parkinson's disease is bradykinesia. That's slowness of movements. So essentially what we do is we look to see if a person is able to open or close their hands. Usually it's unilateral. One side or another will be slower. There's other supportive criteria. There's rigidity. There is a rest tremor, usually 4 to 6 hertz. They call it a pill rolling tremor. And then there's later in the course of the disease postural instability. That's not caused by a visual or cerebellar problem. It's due to the disease itself. The other test, what we want to do is to exclude other causes of Parkinsonism. And then there's supportive criteria, the unilateral onset, again, the rest tremor, progressive disorder, persistent asymmetry affecting the side of the onset the most. There's usually an excellent response to levodopa, 70 to 100% improvement of symptoms, and the clinical course is usually 10 years or more. So now there's certain goals and principles we use for the treatment of Parkinson's disease. There's no definitive protective or restorative effects with medications as of yet. Now, there are something called MAOB inhibitors, and these help prevent the breakdown of dopamine itself. They've shown promise in modifying disease progression in Parkinson's disease. Exercise itself has shown to reduce the loss of dopamine neurons in MPTP lesioned rats. It also induces growth factors. As you can see here, brain-derived neurotropic factor is one of them. Now, again, there are no protective or restorative effects with medications as of yet, but we can, in the L-dopa study, can you hear me?
I'm having a little
Yeah.
We can't hear you down here.
Jasmine, is there any way we can get this on, or
There's a different microphone.
can we try to get that? I'm sorry, I'll try to talk loudly and okay, I apologize. So there's something called an L-dopa study. They did this in about 2006 and indicated that levodopa, the Cinemet, carbidopa, levodopa, may actually have neuroprotective properties, that medication itself. And for years, the old school way of thinking was that we spare levodopa therapy. We hold on to that. We only use it at the end because of these complications, which I'll show you later. But they're showing now that actually it can show some effects in preventing the course of the disease later on. This is the study that proved that. So they looked at levodopa. They followed patients on it for 40 weeks. They then took off the levodopa. They discontinued that for 2 weeks, which some thought was not a full washout period. That was their major complaint for that study. But the patients that they had on levodopa then took off for 2 weeks showed that they had a significant reduction of symptoms even when they weren't taking the levodopa after 2 weeks. So basically what that's showing is that you put that medication into somebody's system, it can actually help out with Parkinson's and prevent some of the portion of the disease. Most importantly, physical therapy, exercise is useful in all stages of the disease. Better motor performance is seen in patients with Parkinson's who exercise intensely and regularly. Obviously, we want to maintain independence. We want to make sure that everybody can live as fully and as long of life as possible. The drugs, I'm not sure what happened here, sorry. The drugs help the symptoms, but they may not stop the disease progression. So again, 75% of the patients have complications of the levodopa therapy, which is why in the old school way of thinking was to prevent and just to not use this medication until later. The 5 major responses that people have after the 5 years of levodopa therapy are the troublesome fluctuations. 25% will have a smooth or a good response. 20% will have troublesome dyskinesias. Dyskinesias are excessive involuntary movements. 8% have a total or substantial loss of efficacy, and 4% have toxicity at therapeutic or subtherapeutic doses. And again, that's 4%. That's a very low percentage overall. So in order to maintain independence, going back to the levodopa therapy, younger people tend to develop motor fluctuations and dyskinesias with the medication, but older people can develop confusion, psychosis, sleep-wake alterations. Sorry. Now, we want to individualize the therapy. There's obviously therapeutic goals, but each person is a human. It's individual for each person. So we need to consider the symptoms, degree of functional impairment, and the expected risks and benefits of the treatment agents. We have to determine the issues by identifying the most troublesome symptoms, and then we attempt to treat the most troublesome symptoms. Obviously, our goal is to maximize one's quality of life. So the pharmacological treatment of Parkinson's disease, I want to go over the major classes of medications that we're using currently today. So I first wanted to show you, just to get an idea, this is a patient with Parkinson's disease off of his medication. This is where I did my fellowship at University of California, San Diego. So you can see the significant tremor that he has in both hands. This is looking at the bradykinesia, that's that slowness of movement. You can see how difficult of a time he's having. It's a wonderful gentleman. You can see it's even worse on the left-hand side, and that's usually the case in Parkinson's. It affects one side more than the other side. The hand opening and closing is another way to detect for bradykinesia. He's doing a pretty good job there. But you can see there's a decremental response after a period of time. This is called a re-emergent tremor. We use this to try to determine if it's an essential tremor or if it's Parkinson's disease. A re-emergent tremor comes back after about 10 seconds. The hands initially go out, then after a while the tremor will develop. We test for rapid alternating movements. And this is all part of something called the Unified Parkinson's Disease Rating Scale Motor Examination. Also, we're testing for bradykinesia again here. We're testing for postural stability. His walking is actually fairly decent. His major problem is instability, but a lot of times people have en-bloc turns with the shuffling, smaller amplitude of gait. We got a Spanish lesson here too. Okay, so his postural stability is good there as well. Okay, so going back to this. Oops. Okay. So now, actually, this is the same patient who is on medication. And this shows you the significant improvement that one will have when they take a levodopa therapy. So you can tell, obviously, that the tremor is basically gone on the right side. He still has it on the left side. The movements are much better, much more fluid. It's amazing.
So one on the right?
The left, there's still the problem. That's the predominant side, but it does help immensely.
So it is three on the left.
Okay. And you can see that's much improved as well overall. This is the left side again. This is the troublesome side. Thank you so much. Can you hear me better now? Okay, yay! Fantastic. Yeah, I'll try to. I'm not sure where the sound is, sir.
On the left. So the tremor.
I won't talk while this is going. We'll just watch the video for now, and I'll discuss what we're seeing afterwards. Okay.
So if you could be. Bravo. 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 Bien.
So as we're competing for sound, I'm going to go ahead and describe what we're seeing. So obviously there's a significant improvement in the slowness of movement. His tremor got a lot better. His rigidity, you can't really see it there, but that's another cardinal symptom of Parkinson's that improved greatly as well. His walking improved. That's the Unified Parkinson's Disease Rating Scale score. And overall, he went from a 50 to a 20, which is a very significant improvement. And that's just from regular levodopa therapy. Okay. All right, so the therapeutic options for Parkinson's disease, we spoke briefly about the MAO-B inhibitors. That's the first-line medication. Dopamine agonists are another type of medication. Carbidopa, levodopa, that's also called Sinemet. IPX066 is Rytary. Duodopa, it's an intestinal gel formulation. We'll go over that as well. Botulinum toxin injections are an adjunctive therapy for Parkinson's. Deep brain stimulation is another adjunctive therapy for Parkinson's. And we'll talk about clinical trials as well. So the MAO-B inhibitors, there's two major kinds of them. There's rasagiline and selegiline. There's this DataTop trial, deprenyl and tocopherol antioxidative therapy of Parkinsonism DataTop study. So they gave selegiline 5 milligrams twice a day. It showed that it delayed the symptomatic treatment by 9 months of Parkinson's disease. So again, the idea is to avoid or to spare levodopa until later on in the course of the disease, and that's what this medication did. The blind date trial was a similar trial. They had subjects on selegiline. They showed that they required lower dosage of levodopa. They had slower rate of worsening of symptoms and signs of Parkinson's and less freezing of gait. The tempo and adagio trials, basically they showed that rasagiline, which is another form of an MAO-B inhibitor, it can actually reduce the rate of clinical worsening in patients with Parkinson's disease. And there was the tempo trial, which showed that 2 milligrams of rasagiline had a superior result over 1 milligram. The adagio showed that only the 1 milligram dose was superior to placebo. So overall, we recommend starting with in early Parkinson's disease with an MAO inhibitor. It does show that it slows down the progression of the disease in these two trials. You want to use less than 10 milligrams a day of selegiline and less than 2 milligrams a day of rasagiline. I put down here the dollar signs because the rasagiline is actually quite expensive through insurance companies. So if you are unable to obtain it through your insurance company, I recommend selegiline. It will give you the same effects. Pharmacists often caution patients about interactions with antidepressants. They'll say that it's going to cause this tyramine reaction. That's not possible at the doses that we give this at. That's why we keep it at less than 10 milligrams a day or less than 2 milligrams a day. The dopamine agonists are, again, this is more of an old school way of thinking for Parkinson's medications. The idea was to spare the levodopa therapy for as long as possible. These are some of the medication types. There's ropinirole, which is also called Requip and Requip XL. Pramipexole, also called Mirapex and Mirapex ER. There's a transdermal patch, rotigotine, which is also called Nupro. That is probably my favorite and the most physicians' favorite medication for the dopamine agonist. It gives a smooth release throughout the day rather than giving a brief burst of the dopamine agonist. But it is important to note the dopamine agonist monotherapy is rarely successful for more than 3 years. So the major side effects, and you'll see me reemphasize this again, for dopamine agonists, the mnemonic I underline is NOSH, N-O-S-H. So nausea, orthostatic hypotension, somnolence, and hallucinations. Now, those can happen with Sinemet also, with carbidopa, levodopa, but they're more pronounced in dopamine agonists. Orthostatic hypotension may be an unfamiliar term. Essentially what that is when one stands up, they get very lightheaded, start to feel woozy, and then they can fall. Somnolence is a more familiar term. It's basically just daytime sleepiness. But in dopamine agonists, it's very important to monitor for this. You can actually require to take modafinil in order to stay awake due to this. Hallucinations are very rare in both dopamine agonists and with cinnamon. The biggest concern that we have is the impulse control disorder, especially here in Las Vegas. Compulsive gambling, shopping, sexual behavior, impulsivity may lead to falls. It can also cause leg edema. We standardly will check for this as well. That requires compression stockings and elevating the feet above the level of the heart. Another problem with the dopamine agonist is that you can get something called a dopamine agonist withdrawal syndrome, and it's also called DAWS. It's not relieved by levodopa. It's essentially a withdrawal syndrome that causes anxiety, panic, agoraphobia, depression, diaphoresis. You can have the orthostatic hypotension, fatigue, pain, drug cravings. If you are feeling these signs and you're being pulled off a dopamine agonist, you need to let your physician know ASAP so they can modify the regimen. The point is we want to gradually reduce the dopamine agonist. We don't want to discontinue this immediately. We don't want you going through this. Now, carbidopa, levodopa, cinnamate, that is the mainstay of Parkinson's disease. There's different formulations you'll see at the top. There are 3 different versions. There's 10-100, 25-100, and 25-250. Really, you want to stick with 25-100. I don't know any movement disorder specialist who will prescribe the other versions. And so the reason is you have a carbidopa, which is the first number, then levodopa is the second number. So carbidopa helps prevent the peripheral breakdown of levodopa in your bloodstream. So what that does is it reduces the risk of getting the side effects from levodopa in your blood. So that's why we try to, some people actually increase the carbidopa-levodopa equivalent, so it's 50 to 100. But you'll see in these versions we have 10 to 100, 25 to 250. That's 1 to 10. That's too little carbidopa, and you can have a lot of unwanted side effects from that. So to determine if somebody's actually getting a response from levodopa, we do a titration schedule, and we'll start off with the first week. We go low and slow, usually a half tablet a day for the first week. Next week, 1/2 tablet twice a day. Week after, half a tablet 3 times a day. It's going up very slowly. You're not really going to see the response that you want until about week 6. And these are this is a sample of what we usually tell people when they're titrating up on cinnamate. You don't need to reach the top dose. You can stop at the dose you feel is helping your symptoms. If this titration scheme is too fast, you can go even slower. Don't go to the next dose if you're experiencing some side effects. Continue with the dose that makes you feel most comfortable with your activities of daily life until you come back. So a sufficient trial of the carbidopa-levodopa is considered basically 600 milligrams a day, and that's 2 25-100 pills 3 times a day. The symptoms that respond the best are bradykinesia and rigidity. Tremor can be a little bit more resistant. There are other medications we'll talk about that can actually help with tremor. The reasonable high dose of levodopa before concluding efficacy is 2,000 milligrams a day. That's an extremely high dose. Rarely will you see anybody on that. But again, understand that is approximately 5 pills 4 times a day. You're rarely going to get up to that dose. So, and again, I wanted to go over the side effects that can occur from the carbidopa-levodopa, and you see the mnemonic again is NOSH, nausea, orthostatic hypotension, somnolence, and hallucinations. And with the carbidopa-levodopa, you can have dyskinesias. And that's, again, the excessive involuntary movements. And I put down here amantadine. That's the medication that we give in order to help with those. Another problem with the levodopa therapy in general is these fluctuations. We call this an off versus an on period. So an off period is when the medication is not working. It's a subjective state. It's when one doesn't feel that the medication is actually improving their symptoms. The on period is when the medication is in the bloodstream and it's actually working. Now, as Parkinson's disease progresses, the duration of the levodopa dose shortens. But in general, the medication lasts about, the half-life is 90 minutes. It should stay in your system for about 4 to 5 hours each time you take a pill. Now, yes, sir?
You were talking about some of the effects of the carbidopa-levodopa
Yes.
Does cramping, muscle cramping, get involved? What do you think is?
Yes, sir. Excellent point. And I think I discussed it a little bit later, but it's part of the off state. It's called an off dystonia. Dystonia is essentially excessive muscle action, a contraction. Do you happen to get it? Is this, okay. Do you happen to get it in your calf?
Yes.
Yeah, that's a very common place. Does your foot, sorry, I'm not sure why this isn't working. Does your foot ever go like that? No? Okay, that can happen often also. Okay, so the first thing you want to do is, this is just a rule of medicine in general, is less invasive the better. There are Botox injections, and we'll talk about that later, but I'd rather not have anybody I know go through a Botox injection. So the better way to do it is to make sure the medication is in your system in a more thorough way throughout the day. Most people get the off dystonia at night. I'm not sure if that's when yours happens. You're probably stopping taking Sinemet around 6 or...
6 o'clock.
Yes, sir. And then imagine by 10 o'clock it's out of your system. And so that's why you're having that. So that brings us directly to the next point. So Sinemet CR, it does, it's perfect. Sinemet CR, it's useful as a first-line drug in patients more than 70 years old. It lowers the peak plasma level, but there's less of the side effects, drowsiness and confusion. The pre-bedtime dose may increase nighttime mobility and can have excess delayed response. There's the risk of the severe sustained dyskinesias, a less predictable response, but this is getting to your point. Actually, did I show it in here? I think I took it out. But basically, the only time I really like to use Sinemet CR myself is at bedtime. That's when I give it to patients. And so take your normal dose of Sinemet instant release during the day, add on a tablet of Sinemet CR at night, you'll get a more sustained response throughout the night, and that should avoid that complication for you. So these are the other way we can treat fluctuations. Entacapone is a COMT inhibitor, prevents the breakdown of carbidopa, levodopa, prolongs the half-life of levodopa. I tend to stay away from it. It can cause a lot of dyskinesias, especially earlier on when used with Sinemet. The Sinemet CR, again, the data is not very good for it. It was supposed to give this steady response throughout the day. I really reserve it mainly for nighttime. It's not shown to avoid fluctuations, and it's better to use small divided doses of Sinemet IR in my opinion. And then rasagiline and selegiline can also help avoid fluctuations because it slows the enzymatic breakdown of levodopa itself. Now, this medication, I think this is a great medication. This is IPX066 or Rytary. It has immediate release and extended release beads. So basically it dissolves in the GI tract at varying rates. The point being, with Sinemet, you're getting this immediate dosage and then it kind of wears off. It's a plateau, peak, and then drops. So with the Rytary, you're getting more of an even release. You get the instant boost, but then you also get the controlled release effects of it. So it's divided up into carbidopa, levodopa in a 1:4 ratio, similar to the 25-100 for Sinemet. And you can see the numbers are very confusing. It's 23.75, 95, 36.25, blah, 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 blah. It provides, again, the initial and extended levodopa plasma concentrations. So there was this study, and it compared basically Rytary, the IPX066, with Sinemet IR. It's given to 393 Parkinson's disease patients with more than 2.5 hours of off time per day. And they showed that if you give the Rytary 3 to 6 times a day, more than compared to the Sinemet IR, it reduced the off time by 1.17 hours per day. They did find that you have to give about twice as much of the Rytary as you did for the Sinemet IR. The adverse effects were basically the same over the 13-week period. This seems like a substantial amount, this 43% and 40%, but these are minor adverse effects. They're not the significant ones. They're not orthostatic hypotension and hallucinations. It's a little bit of nausea when they first take it, they get used to, and things of that nature. The conclusions of the study were that many Parkinson's patients with motor fluctuations can be switched from Sinemet to Rytary with reduced dosing frequency, reduced off time, improved functionality, and improvement in some measures of quality of life. So here's a conversion chart. It's a little bit confusing again, but basically you want to take about twice as much Rytary as you were going to take of the Sinemet. This study actually compared the pharmacokinetics of the Rytary with immediate release Sinemet, sustained release Sinemet, and the carbidopa, levodopa, indicapone, Stalevo. Excuse me. The study conclusions were that the carbidopa, levodopa instant release, you reach your peak concentrations in 1 hour, but then that decreases rapidly, less than 10% of peak by 5 hours. So that's why you notice some of the off symptoms at night. Sinemet CR and Stalevo, they compared those two. They reach the peak concentrations at about 1.5 hours, but then by 6.3 hours for Sinemet CR, 7.5 hours for Stalevo, you have less than 10% of the concentration you want. However, for the Rytary, you reach the peak concentration at 4.5 hours compared to 1.5 hour or 1 hour for the other versions, and it lasts up to 10 hours before you start feeling the wearing off. So these are my anecdotal clinical observations of Rytary, and I tried to incorporate what other people have noticed as well. It decreases fluctuations. You may not get the initial kick that you got with Sinemet IR or with dopamine agonists, but you have less dyskinesias. It can take time to convert the dosing properly. You have to take the delayed onset and sustained benefit into account when you're looking at patients. Determining if the patient is off or on may be more difficult. That can be more difficult when we're assessing. And there may be problems with insurance. That's honestly the biggest problem that I think I've seen with Rytary. Otherwise, I would recommend it for basically all my patients. So this is a Duodopa. This came out recently. They also call it Duopa. It's a levodopa carbidopa intestinal gel. So it's an intrajejunal percutaneous gastrostomy tube. So what it does, it gives a continuous drug delivery into the gut. So you avoid going through the stomach and other areas that can actually interfere with absorption of levodopa. So the indications really, and I'm going to spend a small amount of time on this, is it's for advanced severe Parkinson's disease. It's for severe motor fluctuations and dyskinesias that are resistant to conventional therapy. You have to have a satisfactory response to levodopa in the first place in order to take it. The ability to tolerate the surgery and have social support are very important as well. The contraindications to using this are pronounced dementia, medical contraindications to abdominal surgery. So my anecdotal clinical observations of Duodopa, it's again reserved for very severe advanced Parkinson's disease. It does help to reduce fluctuations and dyskinesias. But you have to come into the clinic all day to adjust the bolus and get maintenance doses, which can be kind of a hassle. The patients often need caretakers to administer the levodopa carbidopa gel. The tube can get dislodged, and that requires a GI specialist. I know one gentleman, his physician, who has this, and he's had his tube replaced 11 times. So I really don't want to give this to somebody. I'd rather avoid that if possible. Something that people really don't know a lot about is botulinum toxin injections and why they play a role in Parkinson's disease. So again, this is what Botox does. You have your nerve, you have your muscle, there's a communicator in between it. Botox cleaves the communicator for about 3 months. So it blocks the signal to the muscle, reduces the muscle contractions. So the indications, as we were discussing, dystonia. So dystonia are sustained muscle contractions frequently causing twisting and repetitive movements or abnormal postures. There's a sensation of tightness and rigidity. It can be intermittent, so it comes and goes. Another very frequent thing that happens in Parkinson's disease is sialuria. It's a fancy way of saying excessive salivation and drooling. It's the overproduction and reduced swallowing that causes this. So here's an example of cervical dystonia, which is frequent in Parkinson's disease and also has its own disorder. And you can see the gentleman here, his head is tilted to the right. It causes severe abnormal posture, often causes tightening, stiffness, and extreme pain in certain cases. This is a focal foot dystonia, and hopefully yours is not getting as bad as this. But this can get very severe. There's other forms of dystonia in Parkinson's disease. There's a task-specific dystonia where actually only occurs when doing certain things such as writing. On B here, on your upper right, is something called a striatal toe. The toe actually extends upwards. You can see and see the cervical dystonia, the neck stiffness, as well as the arm. And D, you can see while the person's walking, this is a truncal dystonia that can happen as well. This is evidence of cervical dystonia. This is a patient who had botulinum toxin before. You can see the severe abnormal posturing on your left and the normal head position on the right. But Botulinum toxin, basically it takes about 2 to 4 days after injections before you notice an improvement. The maximum clinical benefit is usually about 6 weeks after the injections. It tends to wear off after approximately 10 weeks, and most people need injections every 3 months. It sounds daunting at first, but people start to look forward to those 3 months. It's really kind of exciting. I give the injections here every Friday. We have a clinic. I don't get extra money for it. I'm not trying to sell anything. But it's a very helpful way to ameliorate some of the symptoms in Parkinson's disease.
And most insurances cover that?
They do. And Medicare will, we actually were just emailing about it. Medicare automatically covers at least 80% of it, so there's no pre-authorization required. Yeah. Yeah, exactly. And that's the biggest obstacle. We're trying to provide care, and the biggest obstacle that we experience is insurance companies. So we're all on the same side here. This is a physical therapy program for cervical dystonia, a study of 20 cases. The botulinum toxin is the best therapeutic option for patients with cervical dystonia, the neck stiffness. The physical therapy can be added to the treatment to achieve better results. And what they usually do is a combination of motor learning exercises, kinesiotherapy, and the functional electrical stimulation of antagonist muscles. It's a fancy way of saying a TENS unit, which I'm not sure if any of you have ever used. It's simply an electrical stimulator that goes in the neck, and it provides a kind of a pulse sensation to the neck. But the Botox and PT group showed a greater improvement than Botox alone in pain and disability. There are special considerations for the therapy of dystonia. I include this, actually, I kept this initially, I showed this to physical therapy, but it's also useful for you to know that if you do have prolonged immobilization of a limb, such as getting a cast, it can cause a peripheral dystonia, something to consider if you have the opportunity of not using a cast. The Botox adjunctive therapy should focus on decreasing pain and improving functionality. If you do give too much Botox, there could be excessive weakness. It's very important to monitor for, especially if you're walking and you get in the lower extremities. Speech therapists should monitor for problems with swallowing or problems with speaking after Botox injections. My motto is low and slow with basically everything that we give. I always knock on wood. I have to do it again. I'm very superstitious. I have not had anybody who's had the swallowing problems with botulinum toxin injections, so I'm just hopefully keep that going. But it's important also to manage your expectations. It's not going to be a cure, but it will also help significantly. Now, deep brain stimulation for Parkinson's disease it really is, in the right situation, a miracle for Parkinson's disease. So I wanted to show the patient, this is before he had DBS. Okay. And this is one of my favorite patients. He's a wonderful man.
Can I have you count backwards from 20 to 1 by ones? 20, 19, 17.
Figured it out. Volume off. So anyway, so you can see with this gentleman, he's got a tremor in both hands bilaterally, the resting tremor. You can also see the mass facies, which are common in Parkinson's, the expressionless stare that happens. You can see the right leg, that is a tremor, that's not anxiety. The right side, a little bit of a decremental response after a while when he tries to open and close his hands. Left hand, you'll see that starts to slow down after a while. We usually do this 10 times, and we look for a decremental response, which is kind of a slowing after a bit of time. He's doing the rapid alternating movements. You can see the difficulty that occurs as he repeats it. And again, the tremor, and you can see on the left, it's a very bad tremor. And I guess while we're going through this, I'll explain real quickly that there's 3 different kinds of tremor. There's a resting tremor that occurs when your hand is just resting on something. There is a postural tremor that occurs when, for example, you're holding the paper. There's a kinetic tremor that occurs when you're eating food, for example. The resting tremor is more for Parkinson's disease. Okay. And the postural and kinetic tremor are more for essential tremor. And that's one of the ways we try to distinguish the 2 disorders. So I'm going to go ahead and show you the post. Okay, so same gentleman. I have to wait for this to load, I'm sorry. There we go.
Very still.
Here we go, now it's on. Let's stick with this. But you can see here, again, the bradykinesia is basically absent at this point. He can do this 10 times. There's no decremental response. The left side is moving very fluidly. Right side again, very fluidly. He still has a tremor of the left hand, but it's much reduced. Please keep in mind what he had before the surgery. The left is still a little bit troublesome there. But look, he's moving, I mean, this is perfect. Except for that one miss right there. But. And you'll see in his feet as well. The toe tapping is excellent, much improved from what it was before. And one of the things you can do with DBS is you're reducing the amount of levodopa that somebody has to take as well. So you're not going to have the complications. You won't have the dyskinesias. You won't have the somnolence, the nausea, things of that nature. So I have a few more things I want to show you. So, but this just gives you an example of how much of improvement you can get from this. So this gentleman in particular, there's two different targets that they'll go through for Parkinson's disease. They'll go through either the subthalamic nucleus or the globus pallidus internus. The subthalamic nucleus is a little bit more severe for more severe symptoms. The globus pallidus interna is more for minor symptoms. There's a bigger risk with subthalamic nucleus. You can get dyskinesias, sometimes disinhibition. The globus pallidus interna is less risks but less benefits. Either way, you're still going to get a benefit. I don't want to downplay it, but those are things you should know. How DBS works is basically it's a non-destructive, reversible means of disrupting the abnormal function of thalamic and basal ganglia nuclei and their circuits. There are these networks in the brain. Basically, you have an oscillatory circuit going from the basal ganglia to your cortex. And they think that in Parkinson's disease, it's an abnormal circuit. It's going at a certain frequency that it shouldn't. DBS essentially shocks that circuit and gets it back into a regular rhythm. And it's very complex. They have computational models and things that they're working on, but that's essentially how it works. The stimulation parameters are programmed non-invasively post-surgery, so you actually have the implantation put in, then you come back to the clinic and somebody comes and actually goes through the parameters with you. We'll repeat the movements, the bradykinesia, make sure we have optimal settings. There are 3 different settings we can change: amplitude, frequency, and pulse width. So it is FDA indicated for Parkinson's disease. This is the fancy way of saying basically you can give it for the globus pallidus interna or the subthalamic nucleus, and it reduces some of the symptoms of Parkinson's disease and levodopa responsive patients. Now, the inclusion criteria is very important. So obviously it has to be idiopathic Parkinson's. That means natural Parkinson's disease, not secondary to a medication, not another form of Parkinson's. Troublesome motor symptoms despite optimal pharmacological treatment, intolerable side effects to anti-Parkinsonian medication, so we don't want to have brain surgery unless we need to. And you still have to have a clear motor improvement with levodopa. So we do that UPDRS exam that we just did, and there has to be a 30% improvement when doing that examination. The exclusion criteria, these are not very absolute, it's more of a relative contraindications, are significant medical conditions that prevent surgery, dementia, moderate to severe depression. They say age greater than 70, that was more of a previous rule of thumb, we don't do that anymore. Levodopa unresponsive gait and balance abnormalities and intellectual impairment. And again, these are really relative contraindications, they're not absolute contraindications. The evaluation that we do to make sure that it's worth it, this is brain surgery. It's a fairly safe procedure overall, but it's still brain surgery. So we'll do the UPDRS-3 examination, both off and on levodopa. We'll do physical therapy, occupational therapy, speech therapy. And they're going to provide input regarding the patient's overall status, the potential areas of improvement, the limitations, risks, and benefits of the procedure. We do a neuropsychiatric evaluation to look for dementia, MRI the brain to make sure there's no structural lesions that can cause complications when the implantation would be occurring, any other medical issues, and social circumstances. So there's important considerations for DBS. The gait is unlikely to improve. That's one thing that needs to be understood. And it can actually worsen postural instability. They're the two different targets. And again, the STN, greater benefits but greater risk. It can cause disinhibition, personality changes, induce dyskinesias. I kind of like to keep it safer and go with the GPI personally when I was part of the DBS conferences at UCSD. I also want to let you know about the clinical trials that are going on. There is a lot going on in Parkinson's disease right now. So here at our center, we have an upcoming clinical trial. This is for another medication they gave a confusing name for, PF06649751. So going back to those dopamine agonists, all those side effects that can occur, the impulsivity, the somnolence, things of that nature, there's 5 different receptor sites for those dopamine agonists. The previous dopamine agonist only hits D2 and D3. This new receptor agonist only gets D1 and D5. That's the movement sites that we want to get, and we have not had this for 30 years. So it can produce the L-dopa-like efficacy through selective stimulation of this direct pathway, the D1 and D5 sites. And it can improve motor function and can reduce the motor fluctuations or dyskinesias that can happen with levodopa therapy. So it's a way we can give this for a long period of time without developing complications of Cinemet. And this is just an example of going over what I said about the dopamine receptors. D1 and D5 are closely related. D2, D3, and D4 cause the unwanted complications that can happen with the other dopamine agonists. This trial is probably the most exciting that's coming up. This is the SURE-PD3 trial. We all want to stop Parkinson's. We don't want treatments, we don't want Band-Aids, we want to stop Parkinson's, slow the progression, make sure it doesn't happen. So they have identified that Inosine, which is a precursor of urate, it's an endogenous antioxidant as well, as the end product of purine metabolism in humans. So they've shown that urate has been linked to slower rates of PD progression, and it's had neuroprotective properties in laboratory models of Parkinson's disease. Now, it's interesting because they found that actually that in humans who have gout, which is an accumulation of uric acid, that they actually had less of a risk of developing Parkinson's disease. So what we're basically doing is giving this Inosine, which has been proven safe, proven effective so far. We want to make sure it's effective. The way the trials work for clinical trials, there's a phase 1 trial, that's safety, just to make sure that it can be tolerated. Phase 2 is a mild efficacy trial. We just want to make sure it will work if we go on to phase 3. Phase 3 is the trial where we make sure it does work. The FDA is very, very, very conservative when it comes to releasing medications, which is a good thing overall, but it does delay some treatments. Another trial that I'm specifically working on is transcranial direct current stimulation, or TBCS, for improvement of motor function for Parkinson's disease. So essentially they do this thing called a transmagnetic stimulation, and they stimulate the motor cortex. The brain works such that the unilateral cortex will affect the contralateral body. So if you're stimulating the left motor cortex, you can have an improvement of the right side of the body using this form of stimulation. So it can enhance motor performance and cortical function in Parkinson's disease. What they've done so far is show a short term that it can have some benefits, but we're actually taking the study further and want to make sure they can have long-term benefits. So we will be performing this in conjunction with UNLV. There's another medication called sulfonamide that is an MAO-B inhibitor. Going back, MAO-B inhibitors have been shown to be have the neuroprotective effects, and they reduce the breakdown of levodopa. Now, this is a 1,000 to 1 MAO-B to MAO-A inhibitor. So basically it ensures that you're going to get the right receptors. MAO-A are non-selective, and that's when you can have complications with other medications. MAO-B are the one we want to get before we've had these non-selective MAO-B inhibitors. It's also a moderate dopamine reuptake inhibitor. So it prevents the reuptake from dopamine from nerve terminals, makes sure that more dopamine gets out to the other parts of the body. It's designed to increase the on-time, decrease off-time associated with levodopa in the middle and late stages of Parkinson's. Europe is way ahead of us for the most part when it comes to these clinical trials. They approved it in February 26, 2015. My colleagues there say it does help. It's going to be approved as an add-on therapy to levodopa and dopamine agonists, and it's submitted to the FDA on March 2nd, 2015, and it should be available for release in the next few months. So the conclusions, therapists are vital to the management of Parkinson's disease. We can give medications and surgery, but that only goes so far. The two most feared complications of Parkinson's disease are falls and dysphagia, or problems swallowing. We want to avoid these. So, let's see here. Basically, we want to encourage exercise. That's the most important thing. There's only one thing that has really, truly been shown to prevent Parkinson's disease, and that's exercise. So that's what we want to encourage for the most part. 30 to 45 minutes a day, every day. Aerobic exercise, not weightlifting. And ultimately, we want to optimize your quality of life. That's our goal. And thank you very much.
Thank you.
Thank you. Thank you. Yes, sir.
I just want to give a plug to exercise. There's an exercise program here every Tuesday, Thursday. I look forward to the session. At the end of the session, I feel 1,000% better.
I agree 100%. I applaud our physical therapists here in particular. I think they're fantastic. But I applaud your efforts too. It takes, you have to motivate to get up to one
I
exercise.
have a wife who works with me.
Yes, good. So yours motivation, thank you. That's good.
It's
Yeah.
good for me too.
Yeah.
All these body parts that hurt no longer hurt.
Exactly. Exercise is really, it's common sense, diet and exercise, but exercise in Parkinson's disease is huge. It is huge, so keep doing it.
Is there any, my problem is that Tuesday and Thursday I'm here.
Yeah.
So I know I'm going to exercise. Doing it at home by myself, you never get around to it. Is there a tape or a film that can talk you through the exercises so you feel like you're not alone at home?
I don't think and that's a really good idea actually, that somebody should produce this. There's a program called LSVT Big, it's Lee Silverman, and he invented this big therapy. The whole idea is to step high. It's also the one who invented the loud, which is the speak very loud therapy for speech. I don't think he has actually produced any videos, but it's an excellent idea. But that being said, there should be exercise programs for home that they should be providing you. So I would definitely ask for those. You may not get a video, but you'll definitely get a piece of paper with some.
Well, I got the paper. The paper isn't as good as having something that works along with you.
If you have something good to eat, I'll come over. We can work on it.
You're on.
Yeah.
Not too much to eat.
Yes.
I know a gal who has the foot dystonia,
Uh-huh.
and they're bilateral. Would the Botox, because she's saying she has to go for surgery.
And they're probably talking about a tendon release, is my guess, for the surgery. Again, my thinking is less invasive the better. So I would personally like to improve that by making sure, the first question I would ask is, does this occur when you have taken your medication or when you're on the off period? If it's during the off period, you want to reduce that off period and get enough medication in so that it doesn't occur. Because then you can treat it without going in and doing anything invasive. The second line, then I would consider Botox. Botox is transient, lasts 3 months, so it's reversible. If you have any side effects, after 3 months you're going to be okay. A tendon release is a permanent procedure. Anything you're doing permanently is obviously permanent. So I would try the medications first, see if she can maintain an on period that doesn't cause those off symptoms. If she can't get to that, then try the Botox. If that doesn't work, then you consider a surgery, but go stepwise, not the permanent thing first.
And the second question on the DBS, are there manual ways of, because it's sort of like a pacemaker, right?
It is. Your question, no, I'm sorry.
Well, can it be manually altered or?
I see what you're saying. So rather than having to come in and have somebody play with the settings, could it just be a pacemaker that automatically adjusts to your own settings?
Yeah.
They're looking at that. That's probably about 5 years down the line.
Oh.
And your thinking is way ahead of most people, so that's very intelligent. Yeah, but that is what we want ultimately.
And you talked about swallowing,
Yes.
what can be done to help that? And then after the swallowing, we're suffering with reflex.
Uh-huh.
So what can be done?
So in Parkinson's, everything slows down. It's not just your body outside, it's your body inside as well. But there's things you can do for this. So number one, I would say 80%, 90% of my patients have constipation. Constipation backs everything up, then you get GERD, then you get all the other symptoms. So the first thing would be to take care of that. That's very simple. I give most of my patients Metamucil, 1 spoonful a day to take care of the constipation. If that doesn't work, then you go and take a Miralax or do something that you have to do every once in a while. For the swallowing, I always do a speech evaluation. Depends upon the severity. When you go to a speech therapist, they'll give you a cup of water, have you drink it. They'll monitor to see if it goes down the right pipe. If it doesn't seem, or it seems that there's something wrong, they'll do a modified barium swallow. And that's a more, it's a radiological way to evidence and to look at the transit time to see what's wrong. Then they can make their adjustments from there. A simple trick when you eat or drink, tuck your chin. It is the simplest thing in the world. Tuck your chin. Make sure it goes down the esophagus, not your trachea. So that is probably and another thing is, and a lot of people do this, is just make sure you don't eat too much at once. Small bites. Go very carefully. So
And what's that reflex?
the reflux, again, the constipation. Yeah, that would be the best thing. However, reflux could just be reflux on its own. Not everything has to be Parkinson's. Omeprazole, any over-the-counter medication, that should be able to take care of that. Yeah. Yes, sir.
For the night cramping,
Yes.
I've been taking Tylenol PM.
Yeah.
Is that okay?
I don't think you're addressing it. I think you're putting a Band-Aid on something that's not, it's probably your medication wearing off. This is really common. And I would just add on levodopa therapy at night and make sure you're getting a smooth amount in your system throughout the night. The Tylenol PM, one, you're zonking yourself. You're not going to get a good night's sleep. You're probably waking up feeling tired. In those days, you have to take the Tylenol PM. I think that it's not addressing the real problem. It's just putting another Band-Aid on something, which is not really at the source. Yeah. Yes, sir.
I think we had a Richard Steele here about a year ago or so.
Okay.
He has a boxing clinic in North Las Vegas where does exercise.
No, I'm sorry. Please keep going. I'm excited.
No, it's very interesting. I went to it one day and it's very interesting.
They're fantastic. They're fantastic. It helps you with your response time. There are various forms of exercise I really recommend. Boxing is one. Tai Chi is another to help with your balance. I would never have said this 10 years ago. I mean, these are two things I think are absolutely fantastic. And they're also motivating, fun ways to get out and exercise. Nobody wants to, I mean, I do something, run on a treadmill, run in place, you know? So it's a fun way to interact and get out and do things and exercise in a fun way that actually really does help you.
Dancing.
Dancing. Yes, be careful though. Be careful, no tripping and falling. Yes, ma'am.
Would you address the Tuesday and Thursday exercise classes here, what time they are, and if you need to pre-register?
I think we should provide information to all of you about that. I do not know what time they are. If we have your information, I will promise I'll make sure that gets sent out to you. And I'm glad you're motivated to do that too. Yes, young lady.
Oh, I have a question. I was just going to say thank you.
Oh.
Is a
Yes, ma'am.
stabilized bicycle good for exercise at home?
It definitely is. It definitely is. The most important thing, I just saw somebody today who was telling me that they bought a $4,000 piece of equipment that was specialized for Parkinson's. That's not true. You gave somebody a lot of money, and yeah. Just get exercise, aerobic exercise, and make sure it's safe. That's the most important thing. And that's a perfect thing to do.
Well, the problem is my son has a lot of balance problems, so that's why I'm thinking of a stabilized bike.
That's exactly why.
He's falling all the time.
That's the thing. And then the treadmill can be dangerous as well.
Right.
The bicycle is perfect. Aqua therapy is another way to go as well. Swimming pool exercises.
Swimming?
Yeah.
Swimming is good too? Swimming.
Oh, swimming is excellent. Excellent. Swimming is the best exercise in general you can get, and it's the safest form of exercise you can get for Parkinson's disease. Yeah.
Okay.
As long as someone's watching, you're not falling asleep.
I swim three times a week.
Go all out. Yeah. It's very important. That's very good.
1 hour.
That's excellent. They recommend 30 to 45 minutes 5 times a day of exercise, which is kind of unrealistic. It's hard for people to have time to do that.
5 times a week.
Yeah. Yeah.
5 times a day.
Oh, I'm sorry. 5 times a week. Yeah. Excuse me. Yeah. Let's not put that. Yeah. But just try to get as much exercise as possible.
Good.
Yeah,
Walking?
walking is excellent.
How about
Excellent.
heat?
Heat exercise?
Yeah.
It doesn't actually add anything on in particular, and I do get concerned about getting dehydrated afterwards. They have the hot yogas, for example, which, yeah, it can be good, but you're not sweating out toxins. First of all, it's not been proven. And then you get orthostatic hypotension because you're dehydrated, you stand up and you're dizzy, and then you can fall. So I like safer, a little bit safer.
Did our remote sites have any questions? Well, thank you so much, Dr. Bullard, for coming.
It's my pleasure. Thank all of you.